Hey, welcome. Thank you for coming and listening to the Lichen Sclerosus podcast. My name is Kathy, and this is our journal of learning about and living with lichen sclerosus. Each week, I either speak to someone or research an aspect of lichen sclerosus and bring you the information so you don't have to. I bring you the real talk without the medical jargon. And this week, I'm so excited because it has been 2 years in the making, and I finally have her in the hot seat. I'm talking about Leia Mitchell. She is back. Her last episode was one of the most watched episodes, most listened to episodes. So I'm excited to have her back. If you don't know Leah, she stopped for a little while to go to school, and now she is a board certified physician assistant. And she is the primary author of this research paper that we're going to talk about today, titled Fractionated Carbon Dioxide Laser for the Treatment of Vulvar Lichen Sclerosus, a randomized controlled trial. And Mona Lisa laser, which is one of these fractionated carbon dioxide lasers, is a hot topic in the LS community. And so that now you know why I am so anxious to get her in the hot seat to ask her all kinds of questions. So without further ado, I'm going to bring in Leah. Leah, welcome.
Hi, Kathy. How are you doing? It's been a while.
It has been, but we finally made it here, and I'm so excited. Like, we started talking about this research before it was even published.
I know.
I am so excited. So let's start off right from the beginning, and let's talk about why you guys decided that this research needed to be done.
Of course. So, Mona Lisa was talked about widely with our patients. So, I guess to give a little quick background, I worked with Dr. Andrew Goldstein. I was his right-hand man for about 4 years, and then I transitioned into PA school. So with him, we did a lot of research, saw a lot of lichen sclerosus patients. It was predominantly the most of our population. And so we started hearing people talk about, well, my dermatologist has a Mona Lisa laser, or my gynecologist told me maybe Mona Lisa. It's about $5,000. Should I go for it? Should I do it? It's a lot of money, but it seems promising. I would love to not apply clobetasol on a maintenance regimen weekly. So it was a hot topic. And we said, okay, well, let's see if it works. So that's kind of where it started. We don't jump in and use different things like Mona Lisa or different creams or ointments or whatever the new treatment for lichen sclerosus is without the data. We know that our gold standard right now is clobetasol, and we don't want to stray away from that if a new treatment is going to inhibit the progress. So we want to make sure that it is a true treatment and it actually works before we actually provide it for our patients. So that's what got us into the clinical trial for Mona Lisa.
I love that. Yeah, we at LSSN, we follow the evidence. We're all about evidence-based treatments,
Mhm.
and we're all about informed consent, and you can't inform someone without data. So I love the fact that you guys were like, hey, this is coming up. Let's test it. Let's find out for real. So let's talk about what you did to set up the test and how it was run. So what was the trial?
Of course. So what we did is we used, of course, the laser. We had different settings for each patient, but we wanted it to be placebo controlled. So what that means is that we didn't want the women to know if they were actually getting the laser or if they were getting what we called a placebo laser. So we had settings that were just high enough to create the smoke, but not go too deep into the skin and actually cause any changes to the skin. And then we had the other setting where it did increase as the patients progress through the trial to higher and higher levels. So we broke it up in that it was a 2-to-1 ratio. So the women that came in, we randomized them to, because it was a 2-to-1 ratio, one side of them got the placebo and then the other side got the Mona Lisa. So more people had the actual treatment rather than the placebo. And what we require, there is an inclusion and exclusion criteria. It's a long, long list of things that we had to make sure because we wanted to weed out any variables that we could control. So women were not allowed to be on clobetasol or any other form of steroid or treatment for lichen sclerosus for 4 weeks prior to starting. That was our number one most important part or aspect of it. They had to have active disease, so they couldn't come in being in remission. It had to be active. And then those were the two biggest criteria, is that washout period is what we call it, where they weren't on the medication, and then making sure that they did have active disease. So what we did is we did take biopsies at the beginning of each appointment. And we took a biopsy at that time, and then and we'll talk about it more, but we also took one at the end, and that was what we used as our primary outcome for the clinical trial.
And how many did you have in each group? How many participants?
So we had, that's where I'm going to pull up my handy dandy notes here. So we had a total of, it's always hard to remember everybody. So I reached out to be completely encompassing of everything. I reached out to over 300 participants.
Wow.
And a lot of them did not meet the criteria. So then we invited 54 women to be a part of the study. 4 withdrew before even signing the consent because, of course, when you say placebo, a lot of women who have lichen sclerosus say, well, I can't go that long without treatment. I mean, right. My symptoms are horrible and it's like really affecting my daily life. So 4 of them did withdraw once they found out that there was a placebo aspect of it. So all in all, we had 50 women.
Okay.
10 of them we biopsied did not have active disease. So 40 women ended up getting randomized. And then 19 of those women actually received the laser, the Mona Lisa laser. It was actually a 50 to 50 ratio that we did. So half of the women received the laser and the other half received the sham. So 20 women received the placebo laser and 19 received the fraction CO2 laser. 1 was excluded from analysis because they couldn't complete the study. They dropped out after receiving one of the treatments because they just couldn't tolerate it.
Right. Oh, so let's talk about who these women are. Was there like a specific age group? Like what was the age group, racial, what were their demographics?
That's a great question. So the median age was 59. The range was 51 to 64. So a majority of our women were menopausal.
Oh, wow. Okay.
Mm-hmm. And then we had an 88.6% were of Caucasian race. We did have 1 African-American female, and then we had 3 others that we included in the other category. So again, predominantly Caucasian group of women that we had. As we know, it's more prominent in those women, but it does not mean it does not affect all races.
Yeah. And so let me ask you this, and this is just an aside. Was there a particular reason that there were no like younger women in the study?
Usually younger women are not as symptomatic, so it's harder to get those women because they had to be very symptomatic on that was another part of the inclusion exclusion criteria that I didn't go through. We did give women we call it a patient clinical scoring system. So we rated them on itchiness, on burning, on soreness, and then pain with intercourse. And if they didn't have an itching above 5, then we didn't include them in the study because we knew if your itchy level is only about a 5, our ability to make much change it's not going to be as drastic. So we did have to have symptomatic women because part of our scoring, which I will go into a lot more, but a part of our data that we collected was patient symptoms. It was patient symptoms. It was also what they looked like based off of the provider, as well as changes on a histological scale, meaning changes in the actual biopsy. So that was what was super important about our study.
Okay. So those were the 3 outcomes that we were looking at.
Yeah. Oh. So again, the number 1 was the biopsy results. So we looked at changes of inflammation pre and post. That was our number 1 measurable outcome that we had. And then the patient clinical scoring system, which is what I just went over with you. And then as well as the provider clinical scoring system.
Got it. And so, I guess let's go into the provider clinical scoring system a little bit. Yeah. Like how does that work?
Yeah, of course. So we graded it on a few things. One was, okay, how many fissures does the patient have currently? And then that went from a 0, 1 to a 2 score. And the way it goes is 0 is none. 1 is maybe it's just affecting the perineum only. So, and then 2 is it's much more extensive than the perineum.
Okay.
And then we also look at hyperkeratosis. So that's like the thickening of the skin. Again, that's a 0 to 2 scoring. So 0, none, more than 10% is a 1, and then anything above 10% would have gotten a 2. And then we look at atrophy, stenosis, agglutination. So that's if the labia minora and the prepuce have had any scarring.
Okay.
If there's complete scarring of the labia minora and the prepuce, meaning clitoral phimosis, then that gets a level of a 2.
Okay. And so that's in layman's terms, that's fusing. That's what we call it. We call it fusing.
Yep, that's what we call fusing. Yes, in layman's terms, agglutination is fusing. So we look predominantly at the labia minora and the prepuce where we get that fusing.
Okay.
And then the stenosis, of course, in layman's terms, that's how the closing of the entrance of your vagina. So how small has it gotten? And we call that word a stenotic or stenosis.
Okay. Got it. And so on average, as far as like where these ladies started from, do you have that data of like what they were, like how bad they were?
Let's see, actually, yeah. Oh, there goes my headphone. Sorry, give me 1 second. So let's see, I'm going to pull this up. Let's see what we got. So pre-treatment, on average, we had women scored about, let me see what I got here, around, so it kind of varies. I broke it down between active treatment versus the placebo treatment, but it ranged, I would say, the average would be about 8. Would be 8. So most women scored about an 8 in that provider clinical scoring system.
Okay, so that's pretty high, right? Because it's 1 out of 10.
Yeah,
I'm guessing. Okay, wow. So so they were pretty active, and which is good, right? Because then we can see if there's a major a change.
Okay. Yeah, and so it was actually it ranged from 0 to 12. There's one category I hadn't mentioned quite yet. I didn't get there, but it was erosions. So meaning like deep ulcerations. If anyone had any ulcerations.
Okay.
So it's a score of 0 to 12. So yes, they scored on the higher side. So that's why most of our patients had very active disease. A lot of these women that we had, typically we would get ones that clobetasol wasn't working anymore, or maybe they had never been taught how to apply the clobetasol and they found our clinical trial and they said, oh, I just need some type of relief. Right. So a lot of women that came to us hadn't had treatment yet, or they weren't responding to their treatment that they were on.
Do you have data on like how long these people had?
Yes. So a majority of the women have been symptomatic for about 8 years.
Wow. Okay.
So on average, the median that we collected is 8 years. It ranged from anywhere from, 4 to 13 years of symptoms.
Wow. Okay.
Mhm.
All right. So now we have our patient pool. They've been divided up about 50-50.
Mhm.
And how was the trial run?
Yeah, let's get into it. So you all know a little bit. Do you want me to give you background on the laser really quickly before we get into that, or
Sure.
just talk about? Okay.
Yeah, sure. Some people
Um,
don't know about it, so.
yeah, so let's talk about why it even was an idea for lichen sclerosus and why people thought, hey, maybe it'll work.
Yeah.
So what the laser does is they has a certain wavelength that they use, meaning how like a regular wave, the length of that wave allows for something that we call a superficial microablative effect of the soft tissue. So what that means is the laser is stimulating remodeling of your connective tissue. So it's almost like kind of like microdermal ablation, if anyone's heard of that. The abrasions allow for the connective tissue to kind of remodel itself, and it creates this production of a protein specifically with this this heat or this laser. It produces a protein called a shock protein 47, a heat shock protein 47. So what does that do? It means it produces new collagen and a ground matrix to allow for the tissue to grow and develop more collagen, which is the kind of the idea behind the laser. It's essentially just bringing in more collagen to the tissue to allow the tissue to regenerate itself.
Hmm.
And then we also do it in a pulse beam protection or a pulse beam manner, which allows to protect the tissue to prevent it from a lot of damage or overheating. And then it's also called a fractional manner in the way that it's delivered. It creates these small spots. I wish I could share my screen because I would show you photos of exactly what it looks like. I know many of you guys have seen photos of women with lichen sclerosus, but it does create these like small dots within the tissue. Um, and it allows you to kind of see where you've treated.
Okay.
So that's the basis behind the laser and why we chose to do it, because or why people think that it is a potential treatment.
Right.
Um, so the
So
method, yep.
essentially, sorry, I just want
No,
to
you're
break it down, make sure I'm understanding. So essentially, the thinking behind it is that we're going to disrupt the damaged tissue,
good.
and we're going to make these little dots with these lasers in the tissue. So then when it regrows or when it heals, basically, then it's
Hmm.
going to heal correctly and it's going to be
Yes,
healthy tissue.
that's exactly the idea
Got it.
behind
Okay.
it. And that's where like, hey, maybe this will be a great treatment option, but let's test it before
Right.
we just provide it to patients willy nilly without knowing what we're doing or if it even works.
Right.
Um, so to answer your original question, sorry, I kind of digressed there, but the methods and kind of how the whole clinical trial worked. So again, we had 50 women that we brought in. Eventually, 10 of those were excluded because they didn't have active disease. But the timeline period was we had this 4 week washout,
Hmm.
which means no medication. So if they had been on medications like clobetasol before, then they had a washout period. And then we had a 2 week screening period. So that means you come in on day one for your appointment visit one. And then after your visit one, 2 weeks later, that's when your treatment starts.
Okay.
And then it was a 24-week treatment period. Okay.
Okay.
And then after that, after your final treatment, we had you come back in 8 weeks later to take your final biopsy.
So they got 3 treatments?
No, they got a total of five.
5. Wow. Okay.
Five. Mm-hmm.
Okay.
Five treatments.
Which is good because I hear a lot in the community, some doctors say, "Oh, you need 3 treatments." Some people say you
Mm-hmm.
need 5 treatments. It varies. Or you need, a treatment every 3 months or something like that. So 5 is in 24 weeks is a lot,
Yeah.
so that's good.
So
Okay.
we really wanted to honestly get after it to see if it worked.
Right.
So then, like we said, we did a biopsy at visit 1,
Right.
biopsy at visit 7, and then all of those other things that we discussed, like the participant and the clinical scoring scale that we had. And of note, not only was the clinician blinded and the patients blinded, but also our pathologist, our dermatopathologist who reads those biopsies, had no idea what she just knew she was reading patients that had lichen sclerosus. She didn't know that she knew we were running a trial, but she didn't know who got the treatment or who got the sham treatment. So really, it was a triple blinded study if we really kind of got down to it, which is awesome. You don't get many of those.
Yeah, that's great. So, moment of truth. What did we find out?
So we found out that when we looked at our primary outcome, meaning the histological scoring scale,
Okay. Yeah,
there
let's
was
do it 1, 2, 3. So that way we go into. So the first thing was basically what is the biopsy showing, right?
yep. So
What is
exactly. So the biopsy is our main outcome. Again, that's what was we're banking on to be kind of the best outcome because it's objective. We have no other subjective reasons. A lot of those clinical trials out there are a lot of subjective, like symptom relief, but we really wanted to see, okay, well, is it actually curing the disease? Because
right.
there have been studies out there with clobetasol, hence the reason why we use it now, where they did these pre and post treatment biopsies, and those results showed significant changes in the actual tissue, and it showed that the tissue regained everything that it had lost. So the moment of
And
truth.
wait, and that's
Yeah.
important. I just want to say that's important because that means you are you are honestly treating the condition. You are managing the condition, and it's not just a band-aid that you're just putting over it and you're not dealing with the LS. You are actually dealing with the LS just as if you were using the steroid. If the biopsy shows that you know in the beginning you had this uh the skin was showing the hardening, the inflammation, the collagen, which of course makes the hardening. So if we go from there to now you are looking at a healthy tissue, now you know, okay, this is a viable treatment.
Of course. Yeah.
Right.
And that's super important because, as we all know, I mean, the symptoms of LS can vary so drastically.
Right.
Some women can have very minimal symptoms, especially those premenopausal women who are still in their reproductive years and have a lot of that good estrogen. They tend to be a little less symptomatic, but it doesn't mean that their disease isn't progressing.
Right.
By the time that they have symptoms, a lot of them have a lot of pain with intercourse because they've had so much fusing and the size of the entrance of their vagina has gotten so much smaller that they now have recurrent tearing during sex, or
Right.
they have the covering of their clitoris and now their ability to have clitoral orgasms has either decreased or completely gone away. So it's definitely important to note that even if the patient is relatively symptom free, it doesn't mean that their LS is in remission.
Right.
So to your
And
point,
we're thinking about the progression to vulvar cancer, right?
exactly.
We
Yep.
have to manage the inflammation and get the tissue healthy so that it reduces the percentage of vulvar
Exactly.
cancer.
Because we want to optimally treat our patients so that we decrease that percentage to essentially zero. I mean, right now it's about 4 to 7% if you're not optimally treated.
Yeah. All right. Moment
All
of
right.
truth.
So, moment of truth. Unfortunately, I hate to be the bearer of bad news, but the Mona Lisa laser did not give us any statistically significant change in the histological scale, meaning our patients actually got a little worse.
Mm,
So they actually did not have any improvement. So they had I mean, some people had maybe very minor, but not statistically significant when you do all of the analysis that we did to protract all this data. So unfortunately, there was a regression from baseline, meaning it did not help. Which, was I surprised to see those results? I wanted, well, let's say surprise versus desire. I desired for this treatment to work. I wanted it to work. It would have been amazing. So women wouldn't have to continue using the clobetasol. Like, I want to find a treatment that works just as great for you guys at the less low maintenance. But unfortunately, it didn't work. And it makes sense because we're trending down to really that this is likely an autoimmune disease. And how do we treat autoimmune diseases? By suppressing the immune system that's attacking that part of your body. So how can a laser treatment provide that for you? Right now, most autoimmune conditions are either treated with steroids or these new biologics that they've created, which are, we can always dive into in another discussion. I don't think that's something we can do today, but there are treatments. I know, I'm sure some of you guys have heard about Crohn's or ulcerative colitis. So there's so many autoimmune diseases out there like psoriasis, rheumatoid arthritis. All of these things are either treated short term with steroids, and then you get on something like a biologic or like a Humira. So we're just trying to find what works for you guys. And unfortunately, Mona Lisa laser was not one of them.
Yeah. I want to say too, when you were describing like why people thought this was a good idea, to me, the science didn't really add up either, because while we know that with LS, the collagen, the collagen that's produced is not healthy. It's a hardening, it's a hard collagen. We also know that like taking collagen supplements and things like that, increasing the good collagen, doesn't do anything. So why would taking that same approach of introducing good collagen through a laser, why would that be any different? So
yeah, exactly. And now I will say there have been studies out there that have looked at this for hormonal aspects, meaning women who have what we call GSM, which we call that genitourinary syndrome of menopause, aka you don't have hormones going to your vagina and your vestibule. So we need to get that healthy. And while those randomized controlled studies did show improvement, which that makes more sense to me, because we're regenerating that collagen. But again, that's a temporary. That's something that you have to get on a regular basis. And I, like Dr. Goldstein and I used to love to say, like, that Mona Lisa laser is like a $5,000 fix for a $20 problem, where we can just give you estrogen and testosterone cream that costs you like 5 cents a day, rather than like $1,000 out of pocket every time you get a treatment.
Right. So, okay. So it's a fail on the histology, biopsy fail. All right. So the next one was patient satisfaction, right?
Yes. So patient satisfaction, again, it was not statistically significant. Some women did have some improvement of symptoms, but I will say a majority of them, their symptoms got a little bit worse.
Oh, okay.
With the treatment. Some, again, it's not for everyone, but overall, they didn't have much improvement.
Okay.
Yeah. So there was a reduction. Yeah. Some of them did have a little bit improvement. So with our, they had, minimal.
Okay. And then, and when I was reading over the paper, I saw even the people on the sham side also had some improvement, right?
Yeah. So yes, they did, which also gives us theory of like, that's exactly why we did the sham aspect. So because there is a true placebo aspect. Like if you give someone a sugar pill and tell them that it's I don't know, tell them that it'll increase their sex drive. Well, you're thinking about your sex drive being increased, so therefore you're thinking about sex. So, hey, maybe it's just the placebo effect of telling someone that it works. So
Right.
that just goes to show that all of our future studies for LS require placebo effect. If someone sits there and says, like, oh, I think this is going to work, I think this is going to work, your brain loves to play tricks on you. Like if you sit there and tell yourself you feel great all day, like you'll feel pretty damn good. I mean,
Yeah.
if you really sit there, it's like all about telling yourself how you want to feel every day. But I mean, with LS, it's just
That
so symptomatic.
right.
But it's just hard. So it just goes to show that at the end of the day, whatever study it is, if it is not placebo controlled, find a study that's placebo controlled because you really want to see those true results to see if it works.
Yeah. And I think it's important too that the biopsy was there to kind of back it up, right? It
Yeah,
wasn't just the placebo, it was also, hey, the biopsy is showing that there's no improvement to the condition, and both sides are showing minimal
exactly.
symptom relief. So,
Right.
all
And that's
right.
why we did the study because now we're not the first Mona Lisa study or fractionated CO2 laser study out there, but there were other ones that we had reviewed. And a lot of them, or actually all of them, none of them did objective data, meaning they didn't do this histopathological, aka
Mhm.
this biopsy score that we had. And also of note, a lot of them were also being treated for GSM in addition to their LF. So
Mhm.
some of these participants were also getting, I don't know if y'all know, but the Mona Lisa laser can also go internal. They
Mhm.
have specific ways of doing it. It's like this long, it kind of looks like a wand that you put internal and it shoots out the laser in almost like a 360-degree manner. And they were also doing that. So they
Okay.
were treating women who had genitourinary syndrome of menopause as well as lichen sclerosis. So who's to say that it wasn't their GSM symptoms that were improving versus their LS symptoms?
Right.
So we
Right.
we allowed all of our patients to be if they were on if they were on an estrogen or if they were on DHEA, they were allowed to stay on that during our study because we didn't want to be treating their GSM. We
Right.
wanted to treat their LS, and that's what we did. We never touched their vestibule unless they had active LS inside of the vestibule, which is very not many people have it.
Mhm.
And then we never went inside the vagina, so we did not treat the GSM. We were very specific on the LS, so that's something of note as well because there were some of these studies in the past that were also treating that as well.
Cool. All right. So number 3 outcome, the doctor's visual or the doctor's
Yeah.
aspect.
So there was a regression in the clinician reported disease severity in the active group, meaning the women who had the Mona Lisa. So there was a 0.3 or sorry, a 0.8 increase, meaning it improved
Oh,
by point eight.
okay.
Regression. So, or sorry, regression, meaning it decreased, it regressed
Oh, that's
in
what
the
I was going to
active
say.
group.
Wait a
Yeah,
minute.
sorry.
Regression means they went back.
Sorry. Yes, I always flip up on this when I read it to people. And then for the active, and then for there's a reduction in the sham group. So it goes to show again, placebo control is important, but it's interesting to see that reduction in the sham group, um, and then the increase in the active group.
So the sham group got a little better and the active group got a little worse. That is interesting.
It's all
Do,
interesting.
do
And
you
I will,
think
mhm,
go ahead.
sorry, go ahead.
No, go ahead.
I will say, I also pointed this out in our flaws of our study. You always have to talk about the positive aspects of the study and what could always be better. We had multiple providers that were scoring these patients. So
Okay.
we did this study in New York, but at that time we had 3 separate providers in New York. So there is a provider bias that we had to include in this study. So not all providers, even though we give a detailed information on how to score, not all providers score the same.
Right.
How do you rate how stenotic or how closed someone's introitus is? And that all varies. So I will say that's the one issue that I think is very important to highlight about this study.
Did the same provider score the same patient throughout the treatments, or did they see different providers throughout the different treatments?
Some saw the same providers. It depended on when they came in, but you
Ah,
could have seen a different provider each time. Yeah.
okay.
So
Yeah.
that
So
is, yeah.
yeah, that again, like you said, now you're dealing with the provider uh kind of effect. So
Right.
let me ask you this, because I've seen some criticism of the study,
Mm-hmm.
that because there was in the sham laser, because there was some penetration, and
Mm-hmm.
doesn't matter how much, that made some kind of effect on the study. What do you
Yeah,
say for that?
that's a great point. My argument to that is we actually made sure we consulted with the people that make the laser, and that's how we got our settings. We made sure that it didn't penetrate too deep to actually create an effect. You have to go deep enough in order to stimulate the collagen, especially because the lichen sclerosus is such thick skin that's easy to tear. To penetrate that deep and to actually get enough of that protein I discussed to be stimulated is very minimal. And I will say, if you're trained to the eye, like I was in every single patient appointment, I I obviously knew the settings that were going into the machine. I was the one that was putting them in. But because I knew the settings, I knew I could see the difference.
Mm,
And obviously, there's more significant of a change the higher in the setting you go. You see more the dots become more prominent.
mhm.
But I will say that it is definitely not high. It was definitely not high enough to create any type of change. So
Okay.
any changes that we saw in the results likely could have, especially the provider clinical scoring scale, likely could have been because of our provider biases. Now, if we could go back and change that, I think that what we should have done is just had one provider score it, but that would have been in a perfect world. We
Right.
don't have the same provider at that office every single day seeing those patients. It makes it a lot harder,
Mhm.
especially when you do, and it gets more like that when you do more broad based studies, like studies that are in multiple states or countries. You're going to have multiple providers looking at granted, usually the same patient, but there's always going to be a little bit of that clinician bias, which is all why we go back to the lovely biopsy that we had to take. That
Right.
is where we really put all of our weight on that for sure. Is did this work? Did it not work? And again, there was a very insignificant change from baseline. I mean, to get into the nitty gritty, there I can tell you, I can read out the results. It was a point 0.1 reduction in the scale, meaning improvement. So
Mm.
0.1 is very, very insignificant.
A tenth of a percentage. That's
Yeah,
crazy. Yeah. And
exactly.
so you're paying $5,000 for a tenth of a percentage
Yeah,
of improvement, and you still have to use your steroid, or you still have
yeah.
to use a different treatment.
Yeah. And the
Uh,
highest, I will say the highest increase in that active group was a point 0.9. So they
mm,
got to 1, but it was point 0.9. So
wow. Okay.
not high
So,
enough.
are there any other criticisms that you've heard about the study?
Yeah, I'm going to even just tell you all of ours that we pointed out. So
Okay.
sample size, 40, not ideal, would love more. Hard, very hard to get. I mean, as the recruiter for the study, very, very challenging to get people to travel, even if you pay for their travel. I mean, we had to get them to come in for 5, 6, 7 visits. And that's a lot of travel in a
Yeah.
short period of time. So they were coming to New York. So would love to do like a wide scale study and the next study in the future to include multiple practices and not just ours. Of course, the clinician rating bias, and obviously very homogenous population. We're only looking at the Caucasian female. And as like on a dermatological side, they have what's called like a Fitzpatrick scale, which means essentially how dark is your skin. So now a Fitzpatrick skin types. So we don't know how this laser even works really on people of darker skin colors. Does it work better? Does it work less? We have no idea. So that's a huge aspect of it as well, because we only had 4 women of color in the study out of 40. So that's not a lot. And then there was a lot of variability in the patient population regarding whether they had had prior treatment to LS. Some people it was none. Some people had been on clobetasol for years. So that definitely could have had an effect. 100%. If we could have made it a perfect study, we would be like, no treatment with clobetasol ever, but we wouldn't get any patients.
Right. I was going to say.
We would get nobody to not ever have used clobetasol for lichen sclerosus. Like, that would be so hard. So,
Yeah.
so that is also to point out there that some of these women, maybe because they've been on clobetasol for so long, maybe they weren't getting as many changes. I mean, granted, their disease was active because everyone had to have active disease. So maybe they weren't changing as much because their disease was like moderately taken care of already. I mean, they weren't perfect, but I can tell you that it was a very wide range of active disease. We had like minimally active, but very symptomatic. So that's why they had to be active and symptomatic. Minimally active to very symptomatic to extremely active, like widespread, like some even on their abdomen. So yeah, that's those we did have there were definitely a lot of limitations. While we did discuss all the strengths, it's a great study. We did all that we could, but life gets in the way. Sometimes it's hard to, be benevolent dictators in clinical trials.
Yeah. I mean, yeah, you're dealing with 40 different people's lives,
Yeah,
you got to worry about, is this person coming in when they're supposed to, or is their treatment
exactly.
delayed? And then what are they doing in between time, right? You're taking their
Exactly.
word for them for
It's
and
an
because
honor system.
yeah, because the other thing that I'm thinking about is if their symptoms are active, if they have active LS and they're symptomatic, how are they treating these symptoms, right? What are they doing to treat these symptoms, and would that have any effect on that symptom relief, right?
Exactly. And
Especially the symptom
mhm.
relief and how the skin looks, you know? So
That's a
that's
great point. We definitely were requiring their honor system, essentially. It was on their honor, they're not going back applying clobetasol. And I gave every patient that we had my number, my direct line. They could call me if they needed me. If they had too many symptoms, they would say, "What do I do? I know I can't use the steroid." A lot of these women really, truly want to help the
community.
research
Yeah.
and the community. So that's what's so amazing about these women that have LS. They are very willing to want to help the community and help other women. So a lot of them were very, very good about not using it. Now, that means, yes, I did have a few people drop out because the symptoms were too much to handle.
Yeah.
And those were sham patients. They did
Yeah.
have the sham laser. So they were like, look, I just can't do it. I don't want to mess up the study. I have to use the clobetasol. I can't. I just have to get back on it.
Yeah.
So I will say that aspect. But women, the ones that pulled through and were champions and amazing throughout the entire study, they were using coconut oil or aquaphor is
Okay.
what we allowed them to use for symptomatic treatment, which, as we all know, that does nothing. It's just a barrier so that when something touches your vulva, you're not having awful symptoms. I mean, the symptoms are already there, already bad enough, you know.
Yeah, I
So,
can just imagine just thinking of like the itching and when I had active LS, the itching and how I couldn't help but scratch. And so I'm sure that I was doing damage to the skin, even if it was micro cuts,
yeah,
when you're scratching, right? And so, yeah, I mean, you're right. These women are troopers. Like,
yes,
they all respect to them because you knowingly go in knowing that you may not be getting a treatment. First off, you may not be getting the actual treatment you're studying. Second
yeah,
of all, this treatment that you are studying may not be an effective treatment. And the
exactly.
24 weeks is a long time, you
It's a long
know?
time. And
So,
that's not even including the 4 week washout period, the two
right.
week pre treatment, and then the 8 week follow up. So
Oh,
even 8 weeks after the study, they're not allowed, they're still not, after finishing the last treatment, they're still not allowed to use the clobetasol.
wow.
So it's
So,
even includes that.
did you get any feedback from the participants after the study? Like, like an
So
exit interview or something?
a lot of them gave me feedback. I was transitioning into school as the end of the study was coming to a head. And actually, COVID hit and affected some
Mhm.
patients that were in our results. I didn't go into a lot of detail about this because it was like two different analyses that we had to do. It's
Yeah.
very, very in depth, but we did have to do two different analyses because of COVID and how it affected the study. I mean, these women were definitely troopers, but all in all, like some of these women that were in the study were in a former study that we ran for PRP.
Mhm.
So a lot of them I know very well and have talked hours on the phone with them. And they're doing it because clobetasol never works for them and they want to help other women out there. Obviously,
Right.
they want to help themselves, but they know that research takes its time, unfortunately.
Yeah.
So it was a good study. It was a great study. Sadly, we didn't show meaningful improvement in that histological change. And again, some of the women did have improvement in their symptoms with the active and with the sham. But that just shows that there's like a large placebo effect that we need to
Yeah.
be doing these randomized controlled studies for meaningful lichen sclerosus data and treatment.
Yeah. So just to put a pin in it, this study showed that the fractionated carbon dioxide laser, aka Mona Lisa laser,
Mhm.
is not an effective treatment for lichen sclerosus.
Correct. I do want to say that now it's not an effective monotherapy, meaning it can't be the sole treatment of LS.
Okay.
Now,
Right.
because some women did have some improvement in the active and the sham treatment based on their symptoms, who's to say that if someone wants to have a Mona Lisa treatment in addition to the clobetasol, that doesn't mean that they shouldn't do it.
Right.
If they want to and if they want to pay for it, go for it. It may help kind of boost the symptoms in that other way, but it's definitely not going to like overnight change them from being active to inactive.
Right.
But hey, it may also help your genitourinary syndrome of menopause. So maybe there's a little benefit there. So if you want to get it, but just know you're paying for
Informed consent.
something. Informed consent. Know what you're getting into before you do it, and definitely talk to your provider before. I mean, I would recommend just doing clobetasol because it's less money out of your pocket. But if some people want to spend the money on it, then
Since the study was published, has there been new research on the fractionated carbon dioxide laser?
I have seen one out there recently. It's been a crazy transition for me. I have not been able to dig up a lot of Mona Lisa research recently. Big moves in my life, but there have been some research out there that does kind of say that, well, these are some issues that this study did have, which is mainly what I pointed out to you, especially the provider, the clinician biases that we have. But again, they're not doing biopsies.
Yeah.
Mm-hmm.
So yeah, I think that's really the most important part is
Mm-hmm.
that we're looking at, does this actually heal the skin?
Exactly.
We can
And that's
we want to feel better, but are we reducing the chances of vulvar cancer?
exactly. That's what we need to know.
Yeah.
That is the most important aspect. I mean, if we reduce your symptoms of vulvar cancer, your symptoms will go away because we're reducing that chronic inflammation.
Right.
So that's why we can't just go based off of symptoms. I mean, I can give you, I mean, I'm sure we can put on barriers, and I'm sure barriers help your symptoms, but they're doing nothing for the skin, nothing at all.
Right. Yeah.
So we
Yeah.
really need to find something that changes it on a biopsy level. We need to make sure that the skin is actually improving and the inflammation is decreasing. And we can't do that just based on symptoms.
Right. How somebody feels and looks.
Yeah. And clearly we can't even do that based on just clinician looking. But
Yeah.
I mean, if it's a trained eye and they know what they're looking for, then they can definitely tell you if you're in remission or not.
Yeah.
We don't need to do biopsies just to know that you're in
Yeah.
remission if you're a typical patient. But for a clinical standpoint, we have to have, I mean, the data is what's important. The data is what drives us. The data is what changes our medical field for the better. And that's just kind of point blank. We need that change in the skin to know that it's working. Because how else would we know?
Yeah, absolutely. So now that we know, okay, for all intents and purposes, we have the evidence that shows, hey, this does not work. How do we stop? How do we get doctors to stop pushing the Mona Lisa laser for LS?
Great question. Patient knowledge. The patient needs to be informed. Like, for example, your support network. Huge. I mean, that's an amazing platform for women with LS. And the more we can push the knowledge that Mona Lisa doesn't work, you're literally just handing your money away. The more we can drive out Mona Lisa for LS. I mean, Mona Lisa is not going anywhere, but because some people like it for their GSM. But it needs to be, I mean, it's patient education, patient knowledge, and of course I've presented this at an international society for vulvar dermatological diseases. So the more we inform the medical providers, the people that are seeing these women, the more we inform gynecology, dermatology, the less it'll be used. I think it is. I feel like it's being used less from talking to our new LS patients. A lot of them aren't bringing up the Mona Lisa anymore. A lot of them have already been started on clobetasol, which is a huge change from even the past 2 years. I mean, I left, I went to school, and now I'm back, and just like listening to the changes, things have changed, and in a good way. And I'm very excited. I know it's very exciting. It's exciting it's kind of nice to remove yourself from. I mean, I'm so glad I'm back. This is what I wanted to do. But it's interesting to remove yourself for a couple of years from something that you do every day, and then you come back and you're like, wow, things have changed. It's like it's nice, and I'm happy to say that the new lichen sclerosus patients that we see have not brought up the Mona Lisa laser. And a lot of them have already been started on clobetasol, but they just haven't known how to use it.
Use it right. Yeah.
or just
Yes,
trying to establish care to make sure that they don't develop vulvar cancer down the road. So we just check them yearly to make sure they're good.
that's awesome. When you presented at this conference, did you get any pushback? Because I'm sure there were providers there that were offering it.
I
And
did. I
what?
did get pushback. Some of them had actually written the papers that I kind of talked about and said, hey, like these were good, but they're not good enough.
Mm,
And I did get pushback. But I think at the end of the day, the data is the data. It's the
mhm.
histological score that we use. Like, I am showing you the evidence that this doesn't work. You can bypass, if I didn't even include the patient symptoms, if I didn't include the provider scoring scale, the data is the data. It still doesn't change it. We gave them 5 different treatments. Even if we didn't do, even if everyone got the treatment, the data is the data.
Yeah,
It wouldn't have changed. The fact that we had placebo, it's not going to change. The placebo effect doesn't affect your skin. It just affects your brain and how you feel.
right.
So I mean, we could have done this study not blinded, and 100% of the patients got the laser, and the only outcome was the biopsy changes, and we would still see the same results.
Maybe somebody needs to do that just to, do a companion to your study
Yeah,
to show, hey, we've basically duplicated the results. There's
yeah.
we don't need to go any further.
Yeah,
Um,
there's no way around it. People just need to stop using it. But I mean, again, some people like it for the genital urinary syndrome and
right.
menopause. But
They,
again, $1,000 fix for a $20 problem.
right. Yeah. And you talked about someone dropped out because of the pain. So
Mhm.
let's talk about a little bit about that because you are burning holes into the
Mhm.
skin.
Yeah. So let's talk about the side effects first. So the side effects of the treatment. One, it doesn't feel great. It definitely is painful. You're again, like you said, it is a lot of heat. And there's smoke. I mean, smoke comes up. You are essentially burning the skin. Um, so women often have symptoms for about 3 days after was about average of what the patients in the study were having. We told them cool compresses, Advil if they needed it, or Tylenol, and then just cool compresses or what helped. The side effects of the laser were there were definitely prominent. Some women had it more than others, but they weren't anything worse than the symptoms they already experienced with lichen
Mm,
sclerosus.
okay.
So they were tolerable. But the participant who withdrew after 2 sham treatments because her symptoms of the LS had exacerbated
Okay.
because she was off of clobetasol.
Yeah. Do you think that the sham laser kind of flared the skin, like flared the LS? No.
No, I don't think so because if it did, we would have had more people drop out.
Okay.
I think just the fact of not being on a treatment progressed the LS and made
Mm,
the symptoms worse,
yeah. Interesting.
which is what we saw in both parties. I mean, we saw it both on histological scale is that the LS got a little worse or
Yeah.
didn't change at all, which was to be expected because we weren't treating the skin. So the LS would progress because again,
Right.
it was over like a 7 month period.
Right. Right. Last question, and then we'll wrap up here. So we looked at in this study this a specific laser, a ugh, fractionated carbon dioxide laser, CO2
Mhm.
laser. I know that there are different type of lasers also being used for LS. The one that I know off the top of my head is the YAG laser,
Mhm.
YGG, and that one I'm told goes deeper into the skin.
Mhm.
And so the thinking is that that one is effective where because it goes deeper, and lives on the basement layer, but the same principles still apply about the collagen and stuff. The science is just not matching up. I know you didn't do any studies on the YAG laser, but do you have thoughts about what you have seen out there?
Yeah, so again, haven't done studies. I haven't seen the data of that exactly, but
Okay.
top of my head, I don't think it'll work. I mean, granted, clobeta, obviously we know clobetasol works. It decreases inflammation. Now, who's to say maybe if you were to do this laser once every month, maybe it would help promote it or help. I just don't see how it's attacking the inflammation though.
Mm-hmm.
Um, it's producing more collagen, yes, but is it actually inhibiting the pathway that's causing the inflammation and causing the scarring and the changes in the pigment of the color? I don't see how that would work, how that would be effective. If you have psoriasis on your, or if you have like a lichen planus on your arm or any other skin condition, would a laser treat it? I don't I don't know that data either, but I know like for alopecia, that's an autoimmune skin disease, or with hair loss, I don't think they're using lasers. They're using topical medications or oral medications to treat that. So why are they treating LS any differently?
Hmm. Great point to end on. Thank you so
Yeah,
much. This was a great conversation.
of
Um,
course.
it was well worth the wait. So
I have to agree. But before we 100% close, I did want to kind of squeeze in something of note is that
sure.
there are some other studies out there. Our same practice with Dr. Jill Kraft and Andrew Goldstein. They're doing a study on a topical medication for lichen sclerosus. So definitely stay tuned. That medication is, I kind of briefly brought it up about autoimmune diseases, but it's a biologic. So it's a medication that's trying to target the exact pathway of the inflammatory response. So it's a more targeted treatment rather than kind of like the clobetasol bomb that we're putting on our vulvas for lichen sclerosus. So stay tuned on that end. I don't know, I obviously don't have the data, but we will eventually. So there's
Yes,
definitely good things coming. And we're going to continue studying lichen sclerosus. This is definitely not the end of our research by any means.
I love it. Is that a pill or is that a topical as well?
Topical.
Topical as well. Okay.
Topical. Yeah.
Are you part of that study now?
I'm not a part of that one because it's coming. I'm pretty sure it's coming towards an end.
Okay.
But that one looks good. I'm
Yeah.
excited for I'm excited to see the results.
That me too. Me too.
Yeah.
Awesome. Well, again, thank you so much. If you want to reach out to Leah, if you have some questions, you can follow her on Instagram at the_women's health_PA. Follow her there. She's putting out content now that she's graduated out of school. She's back. And then you can also DM her there as well. And
Mhm.
if you want to see her, because she is practicing, you can make an appointment at thecbbd.org and fill out their contact form there. Hey. So
Awesome.
again, thank you so much. This was
Of
wonderful.
course. It was so wonderful, Kathy, as always.